Welcome to the second session of teleconference. In our previous session, we discussed about a case related to nervous system, and also we started the case presentation on hematology. Now we will have more discussion about the second case. To discuss the case, we have the same panel of experts. To my right, Dr. Harish Chalani; to his right, Dr. M.S. Prasad; and to his right, Dr. Jagdish Chandra. We have also the student who is representing all of you, Dr. Chetan Grover. She will be making the presentation further, and I will request Dr. Jagdish Chandra to discuss the case.
So, Dr. Chetan, you presented the history and physical examination of this case. Can you summarize the case as far as the history and examination is concerned, and then we discuss the differential diagnosis?
Yes, sir. The case can be summarized as the patient is a 10-year-old female child presenting with chief complaint of fever, followed by petechial rash and bleeding from the gums for the last 10 days. However, there is no history of any drug intake or exposure to radiations, no history of severe body aches, headache or passage of blood in the stools or urine. On examination, there is no hepatosplenomegaly, lymphadenopathy. There is a non-blanchable purpuric rash and petechiae all over the body. There is marked pallor and all the vitals are normal.
So, we have a child who has got bleeding manifestations, mainly in the skin, and there are of various types, petechial hemorrhages, purpuric spots, but as you pointed out, there is no mucosal bleed other than just mild gum bleeding. Physical findings are very remarkable, particularly with the absence of lymphadenopathy and liver spleen enlargement, and you said there is severe pallor.
Yes.
Okay. So, with this finding, what is your diagnosis or differential diagnosis in this case?
So we will keep the possibility of aplastic anemia first of all. The favorable points that go in favor of aplastic anemia are a short history of fever, bleeding and purpuric spots, severe pallor, and however there is no history of any drug intake or exposure to radiations, which is a point which goes against this diagnosis. Another differential diagnosis we can consider is leukemia, but since there is no lymph node enlargement or hepatosplenomegaly, it may not be there. The third possibility is idiopathic thrombocytopenic purpura. The favorable point for this diagnosis is a short history of fever followed by petechial rash, but pallor is out of proportion to idiopathic purpura.
Alright, so this is a good point in the differential diagnosis of this case, that in idiopathic thrombocytopenic purpura, mostly the anemia is proportional to the amount of blood loss. As we see in this child, there are only skin bleeds and very mild gum bleeding. So that is not enough to sort of make the child severely anemic. Now I would like to ask you one thing. This child has a history of fever for about 10 days time, and the bleeding that we see is more like occurring due to thrombocytopenia. Would you like to consider any infection, particularly around this time of the year?
Yes, sir. We will also keep the possibility of dengue hemorrhagic fever in mind, because at this time of the year there is an increased incidence of dengue cases. And but the history of fever was only present for a period of 2 to 3 days. Yes. Right now the child is afebrile, and there is no severe body ache or headaches. Child is quite comfortable, and pallor is of course out of proportion.
Right. So I think I should remind the audience that whenever you get a patient like this who is bleeding, though the hematological conditions are the common things one would consider, but please stay in touch with the infectious diseases that we keep seeing year after year. The dengue hemorrhagic fever can present with such findings, but as Dr. Chetan has pointed out, that fever subsided just after 2 days. In dengue fever, mostly what happens is that 4 to 5 days fever is there, and then around that time, 4th or 5th day, the bleeding manifestations start and the child deteriorates clinically. The condition of the child is fairly stable, yes, plus the constitutional symptoms of body ache, the headache, these were not present.
Yes.
And the severe pallor that the child has, in spite of not losing too much blood, that makes it less likely to be, or rather unlikely to be, a case of dengue hemorrhage.
Dengue fever, sir.
Any other differential diagnosis you would keep, or these are the common diagnoses you will consider? You said aplastic anemia first, second you said acute leukemia, third, though less likely, idiopathic thrombocytopenic purpura. Any other?
Sir, this thrombocytopenia can also take place due to a B12 and folic acid deficiency.
Very right. So, thrombocytopenia could be a manifestation of megaloblastic anemia occurring from B12 and folate deficiency. Usually we see in younger children, though the age is no bar, but this child is a little older, so not that likely condition. Alright, so how will you investigate this child?
Sir, first of all, we will do the routine investigations like hemoglobin, TLC, DLC, ESR, and we will also do a routine urine examination to rule out microscopic hematuria. We will do a peripheral blood smear to see the type of cells. We will check the platelet counts. We will get the coagulation profile done and also dengue serology. And the most important is the bone marrow examination, which is done to rule out aplastic anemia or leukemia.
Okay. So you have described the investigation, the hematological investigations, routine ones and the specific, and probably dengue serology. You said coagulogram also. Can you tell me clinically this looks like bleeding occurring due to thrombocytopenia, or it looks like the bleeding occurring due to the coagulation defects?
Sir, this we can get a better idea after we do the platelet count.
No, clinical examination, the types of bleeding that we are having, does it look more because of thrombocytopenia or because of coagulation defects?
This seems more like due to thrombocytopenia, because there is no history of similar episode in the past. If there are bleeding disorders, then there may be history in the past also, and there may be a positive family history also.
All right. So you mean that coagulation defects, mostly the congenital coagulation defects like hemophilia, etc., they would be early onset. This is a girl child anyway, so those coagulation defects we will not consider. But on clinical examination, the appearance of skin bleeds in the form of purpura and petechial hemorrhages, that is more like a bleeding due to thrombocytopenia rather than the coagulation defects.
Yes, in bleeding, in coagulation defects, we may have bleeding into the joints, there may be joint pains.
All right. So that again is a manifestation of hemophilia, which is out of question here, yes, since this is a girl child.
Yes, sir.
Can you tell me what is the difference between petechial hemorrhages and purpuric spots and ecchymosis? I'm sure you must have heard these three terms in relation to the bleeding.
The petechial hemorrhages are very small in size, they are pinpoint hemorrhages.
Pinpoint 1 to 2 millimeters.
1 to 2 millimeters in size. And ecchymosis are large bruised spots. Larger
than 5 millimeter, and in between 2 to 5 millimeter, we call them purpuric spots.
Yes.
Okay. Now, if you get the hemogram of this child done, HB, TLC, DLC, platelet count, smear examination, suppose this child is a case of aplastic anemia, because clinically most likely diagnosis is that. What findings do you expect there?
We will see, of course, that the hemoglobin levels would be quite low. Child would be suffering from severe or moderate anemia. In TLC, we will see that all the TLC would be reduced. In the differential leukocyte count, we will see that all type of cells would be decreased.
Any particular type of the cell which
especially
will be
neutrophils.
Neutrophils are produced in the bone marrow.
Yes.
So they would be reduced
drastically.
Drastically. Yes.
And platelet counts, of course, also would be reduced. Anything less than 50,000, the platelet count would be less than 50,000.
All right. On peripheral smear examination?
Again, we will see that all type of cells would be reduced in size, numbers.
Okay. In such a case, what is the importance of getting a peripheral smear examination done? Particularly,
this is
to rule out certain other conditions.
Yeah, we can rule out leukemia because there will be some immature or some abnormal cell forms which can be seen in the peripheral blood smear.
Okay. By peripheral smear examination, if there are immature cells, the diagnosis of leukemia can be made or can be considered, but their absence does not rule out leukemia, because you have kept this possibility as a second. There are cases in which the peripheral smear may not have blast cells and the bone marrow might.
Yes. Then we can also see the type of red blood cells, whether they are microcytic or having.
Okay, so if there was pre-existing anemia because of nutritional deficiency, that could be seen as microcytic
hypochromic anemia.
But in aplastic anemia, usually the cells are
normal in
normocytic or slightly larger in size. So that is the finding in the PS. The confirmation of the diagnosis, how will you confirm the diagnosis of aplastic anemia?
So by bone marrow examination. In the bone marrow examination, we will see that usually the platelets will be decreased in numbers, and there will be maybe increase in megakaryocytes in the bone marrow, and
increased. This is the bone marrow will show you aplasia or
hypoplasia or aplastic bone marrow. All the three type of cells will be decreased.
Right. So overall the hematopoietic cells would be decreased, they would be replaced by fat cells and plasma cells, etc. And the all precursors of red cell, neutrophils and megakaryocytes, which are the precursors of platelets, they would be reduced in number. Depending upon whether it is a severe aplastic anemia or mild to moderate, the degree of suppression would be that. Okay. So in the peripheral blood you described there would be anemia and leukopenia and neutropenia along with thrombocytopenia. We call it pancytopenia.
Pancytopenia.
Can you tell me what could be the other causes of pancytopenia in children?
So other causes would be some type of infections.
Okay. Any particular infection you would like to tell?
Enteric fever.
Okay, very good. Enteric fever is one cause where there can be pancytopenia. Very right. Any other? Though that condition would be associated with large splenomegaly, particularly coming from Bihar. Can you think of any condition? Kala Azar is another very important cause of pancytopenia. All right. Just now we discussed your second possibility. There may not be blast cells in the blood, peripheral blood. That also may present with
pancytopenia.
Okay.
Can it be Kala Azar, this child?
So history of fever is very short here and relieved by treatment after 2 days.
Okay.
And plus usually we see a large spleen.
Yes.
In Kala Azar, which is not there in this child.
So pancytopenia without liver and spleen enlargement goes in favor of aplastic anemia.
Yeah.
In the infections, one more infection I would like to tell. Malaria can be associated with pancytopenia these days, particularly falciparum malaria is associated with these findings, though as a complicated malaria only, that would be the presentation. And again the case might have liver and spleen enlargement, because malaria infections are associated with splenomegaly.
Yes.
Okay. If it turns out to be what will be the findings in cases of ITP? If it is idiopathic thrombocytopenic purpura, what findings you will get in the peripheral blood and in the bone marrow?
In ITP, usually the TLC and DLC would be normal. Platelets would be decreased in numbers, and anemia would generally be in proportion to the amount of blood loss from the body.
That we see clinically also, and that would be reflected in the blood examination. And what about the marrow?
The bone marrow may show normal or increased numbers of megakaryocytes.
Okay. So since there is, what is the defect? How do the platelet get reduced in ITP?
The body starts producing antibodies against the platelets. So this results in destruction of the platelets and reduction in numbers.
So reduction of the platelet numbers is because of the platelet destruction. And the marrow is normal, or will try to compensate by increasing the platelet production. So that is why the marrow will show normal or increased number of megakaryocytes. Okay. Can you tell me how will you manage if it turns out to be aplastic anemia?
Yes sir, we will first of all give supportive treatment to the child. We will give blood components for treatment of anemia, like blood transfusion. We can also like packed cells for anemia. We can give platelet transfusion to compensate for the decrease in platelets, and then we can give antibiotics for infection.
If there are infections.
If
yes.
there is an infection.
So this child will need blood component support for his anemia, for his platelet deficiency, and if there are infections, they will be required to be treated by antibiotics. Any specific treatment?
So we
what
can
is the specific treatment for aplastic anemia?
Specific treatment can be given in the form of immunotherapy, which is in the form of antithymocyte globulins and cyclosporin. So immunotherapy would help.
Okay. Any other form of therapy you know of about plastic anemia?
Bone marrow transplantation.
Yeah. Bone marrow transplantation is the treatment of choice for young patients, particularly children and young adults. And if that is not possible because of various reasons like the cost involved, the expertise is not available, and moreover the donors may not be available because we need a matched sibling donor.
Yes, sir.
So we'll end up giving antithymocyte globulin with cyclosporin, which is the immunosuppressive drug.
Yes.
So Dr. Harish and Dr. Prasad, would you like to
this patient, before coming to this present hospital, this patient received some treatment outside also.
Yes,
for
sir.
fever.
Yes, sir. I was considering it, but considering that it was only given for a very short period of time, and patient quickly recovered from it, and so did not keep it as a main possibility.
So why I ask this question, my point is here to say, to convey the message, in cases of fever of acute onset or any fever, please don't use NSAID, non-steroidal anti-inflammatory drugs, because the chances of gastrointestinal bleeding is very high with those drugs. So the safest drug is the paracetamol only.
Yeah.
So that was the message I wanted to convey to the students.
I think it's a nice presentation, Chetan, you have done it, and such are the cases, I mean, this is a message for the student. These are the cases you get. There may be a severe pallor with lymph node enlargement and presence of the liver and spleen, or there may be there is a liver and spleen enlargement, no pallor. So I think you should be ready with different combination of these cases, presence or absence of hepatosplenomegaly, with or without bleeding, presence of the, and as you discussed the various points in a very systematic way, that if there is a presence of the lymph node, fever, and there is pancytopenia along with liver and spleen, one may think of the possibility of the leukemia. So that's how the presentation should go. Nice presentation, Chetan.
Jen.
Okay, I think we have discussed the second case in detail. As already mentioned in the program guide, you will get one non-IMCI case, and there will be two IMCI related case. So out of the IMCI related case, one case will be young infant and the other one will be for the older child. In our previous teleconference, when we had discussed about the pediatrics component, we had discussed both IMCI component, that is young infant and non-IMCI. But today we will have another case presentation related to older child. So those who have any doubts related to how to make a presentation of the IMCI case, you can take this opportunity. Please start asking the questions, because we have not received any communication from any regional center. So I will write the regional centers to give us the feedback about the attendance of the students, and if they have any questions, the experts will be very glad to reply them. So in our next presentation, we will have a IMCI case, and I will introduce Dr. Ritu Saxena. She is representing the students. She has joined us now, and I will request Dr. Harish Chalani to moderate the case. Now I will request Dr. Harish to...
Yeah, so Ritu, you can start with the presentation.
Good afternoon, respected panel of consultants and my dear colleagues. Now I am presenting the case of a 12-month-old child, Asha. She is basically a resident of Surat and she has arrived in Delhi just 2 days back. Her weight is 5.5 kg and she was suffering from temperature which was 38.5 degrees Celsius. The infant's presenting complaints were fever, fast breathing and difficulty in breathing, and this was her first visit to the hospital. She was not having any general danger signs. The child had cough and difficulty in breathing since the last 5 days. The respiratory rate was 54 per minute, which I recounted, and it was again 54 per minute, so I described it as fast breathing. There was chest indrawing present. On the basis of this, I classified it as severe pneumonia or very severe disease.
Okay, Dr. Ritu, just wanted to ask you, you said in this child, your respiratory rate was 54 and you recounted. Why did you recount this respiratory rate? Was there any doubt in the counting?
Yeah, because while I counted it for the first time, the child did not take respiration for 2 seconds. So I recounted it. Like for 2 seconds there was a gap and then...
see, it's not recommended in the older child.
Okay.
Yes, we do agree in the young infant, friends, because the respiration is more periodic in the young infant, and in the older child that problem really does not come. So in young infant, yes, if it is a fast breathing, you do the counting again, and if it is more then more than 60, then it will be fast breathing. In the older child, yes, you can do the recounting. That's not the only thing. Is when you are not sure of the counts, or you have probably missed the few respirations, then only. Otherwise it's not recommended, and one must know the various cutoffs at that age. Okay, fine. So how did you arrive at this classification of a severe pneumonia or very severe disease? We can see at the form, in the recording form, there was a fast breathing and there was a chest indrawing. So how did you arrive at the classification of severe pneumonia or very severe disease?
So for the diagnosis of severe pneumonia or very severe disease, any of the 2 signs should be present. Associated with, along with cough or difficulty in breathing, there can be either general danger signs which was not present in this child, or there can be chest indrawing, or there can be stridor in a calm child. In my patient, there was chest indrawing. On the basis of chest indrawing, I classified it as severe pneumonia.
Okay, fine. So first of all, we use the word classification and not the diagnosis. And please remember that we must take into account the presence or absence of the general danger signs. A child who is having cough or difficult breathing and is having general danger sign, still the classification will be severe pneumonia or very severe disease. Remember the principle of starting from red box and then going to yellow and then going to green. So if you do not have enough signs in the red box, then only you get yellow. Why in fact I asked you this question, Ritu, because this child has got chest indrawing and also fast breathing. So one sign from the red and one from the yellow, but it is or. So chest indrawing or, so that means you require only one sign to make the classification of a
pneumonia.
Okay, severe pneumonia. Fine, you go ahead.
When the child is suffering from diarrhea since the last 3 days and there was blood present in the stool. Child was restless and irritable. She had sunken eyes and was drinking eagerly. And the pinch, when I pinched the skin of the abdomen, it went back slowly. So on the basis of these findings, I classified it as some dehydration plus dysentery.
Okay.
The child also had fever. By history also, plus she was feeling hot on touch and the temperature was 38.5 degrees Celsius. As I already told you in the beginning, she had arrived from a high-risk area of malaria. She arrived from Surat just 2 days back. And the fever was there since the last 5 days. And she was also having runny nose. On the basis of these findings, I classified it as malaria.
Okay. Do you feel the runny nose is a feature of the malaria?
No.
Okay. So how did you arrive at the classification of malaria?
I arrived at the classification on the basis of high-risk area of malaria. Plus temperature was more than 37.5 degrees.
Okay. Just for the viewers, if you see, we can focus the chart booklet. Now, if we see in a box of the fever, and if you come to the high risk, now any general danger sign presence or presence of the stiff neck or bulging fontanelle will make the classification of a very severe febrile illness. Now, if the child is from the high risk and there is none of the sign from the red box, the child will be classified for malaria, right? Which is not the case in the low risk. Okay, so runny nose presence or absence will not make the classification. It is the area, because this child belongs to the high risk area and there is no general danger signs, no stiff neck or no bulging fontanelle. So we will have the classification of only malaria in this. Okay, go ahead.
Then I checked for the ear problem. The child was not having any ear problem. Then I checked the nutrition status of the child. As I told you, the child was weighing 5.5 kg. I consulted the weight for age chart, and as per the chart, the child was falling into very low weight category.
Okay.
Plus, the child was also having visible severe wasting.
Okay.
So I classified the child as severe malnutrition.
How will you assess the child for visible severe wasting?
So I'll assess the child, I'll look at the buttocks. If there will be more than 2-3 folds in the gluteal region, then it can be diagnosed as severe wasting.
So ask the parents actually to hold the child and where you can see the back. So it is normally there is the round curve of the gluteal region. In this, the curve will not be there, it will be flattened. The abdomen will be protrudent and there will be thin leg. So all these features, they go into favor of a visible severe wasting. Okay.
Then I compared my palm with the child's palm, and I found she to be having some palmar pallor.
Okay.
And I classified it as anemia.
Fine.
Then I looked at the immunization card of the child which the mother was carrying, and I found out that the child received the doses of BCG, all the 3 doses and the 0 doses of OPV, all the 2 doses and 0 doses of OPV, and 2 doses of DPT, and 2 doses of hepatitis B, plus measles vaccine in the 9th month of age. But she did not receive DPT 3 and DPT, OPV 3 and hepatitis B 3.
Okay.
So these 3 vaccines are due today.
Okay.
They are due to be given today.
Fine.
Then I assessed the child's feeding. Since the child was having anemia and is less than 2 years of age, the child is still breastfed and she receives breastfeeding 10 to 12 times in a day, and she receives breastfeed during the night as well. But for the breastfeed, she receives other complementary cereal based food as well. She is taking thin khichdi, dal water and biscuits 2 times per day with the help of katori and spoon, and the servings are few spoons only.
Okay.
The child receives her own servings and the mother feeds the child. During the illness, feeding has changed. Okay. She is receiving less quantity during the illness.
So on the basis of this feeding, what are the feeding problems you have found?
Yeah, the amount given is small.
Okay.
It is inappropriate in quality.
So at this age, what are the expected actually? What should be the recommended feeding?
Recommended is, sir, she should be taking at least 1 katori of khichdi or dal at a time, at least 3 times in a day.
Okay, so this child is taking only few spoons.
Few spoons,
And
that only two times in a day.
So remember, the child, the baby who is a breastfed baby should be taking semi-solids minimum 3 times, and as she mentioned, the since the child is 11 months, so child should be taking roughly 1 katori of 150 ml of each at 3 times in a day minimum. So decreased in amount, and there is inadequate frequency. Is the consistency adequate?
Consistency was also poor.
Okay.
Like the mother used to give thin khichdi or dal water, but in this age the khichdi should not be thin and the thick dal should be given.
So how do you tell the mother that this consistency should be of this nature?
I tell the mother that she should not be given dal water at the age of 12 months. She should be given proper dal, 1 katori at a time, 1 katori which will be of 150 ml, or the khichdi should also not be this much thin, the amount, the way she was giving it, and should be given 3 times in a day.
So what is an ideal semi-solid food, how do you explain to the mother in simple language? Because that is the real problem, to explain the mother that consistency should be thick, but how much thick it should be? What we explain the mother is that when you pour from one bowl to another, it should stick to the wall of the bowl. Because if it is too thin, again it will not stick, and if it is too thick, it will be lumpy and it will come down in the other bowl. So it should be thick, or you can say jitna ke sarson ka tel hota hai, thick. So that type is the consistency. So the feeding problem which we have found, it is an inadequate amount, inadequate frequency, the calories or the consistency of the semi-solids was poor, and the feeding has also changed during the illness. Because on that basis you compare what is the child's recommendation, so the advice will come. So that we'll see. So now can you tell us now what is the classification of this whole baby?
The child is classified as having severe pneumonia or very severe disease.
So we can see in our recording form, as it has been mentioned, it is severe pneumonia or very severe disease, yeah?
Some dehydration, dysentery, malaria,
okay,
severe malnutrition, anemia, and feeding problems.
Okay, fine. Now, how will you treat this child?
Sir, as the child is having severe pneumonia or very severe disease, I would like to refer the child to the hospital. Okay. But before referring her to the hospital, I would like to give the first dose of the antibiotics or antipyretic treatment required.
Okay, so pre-referral treatment will be provided?
Pre-referral treatment will be provided to the child. First I'll give her injection chloramphenicol, which is 180 gram is there in 1 ml. I'll give the child 1 ml iron stat.
Okay. So apart from chloramphenicol, what else you would give in this child?
I'll give syrup chloroquine 7.5 ml stat. Syrup chloroquine contains 5 ml contains 50 milligram base. I'll give 7.5 ml stat.
But that is there in the yellow classification, so how you are giving that?
But since I classified the child as malaria, I would like to give first dose of the chloroquine. I can't give any other thing like primaquine because the child is still 12 months of age. Only after the age of 12 months.
Okay, so I just wanted to explain for the easiness. Whenever you are referring a child, all the treatment of the red box is to be given. So that is what you will find here. The classification was severe pneumonia or very severe disease. So give the injection chloramphenicol and refer urgently, right? This is what the treatment has to be given. Plus the other classification, the yellow and the green, you will find the bold letter treatment. So in this child, for example, this child was having some dehydration. So can we focus here? Some dehydration, since the child is accepting or the child is not vomiting, so this bold letter treatment of the ORS is to be given on the way, right? So that is how. And similarly for malaria also, we will see here after making the peripheral smear, the bold letter treatment of that malaria box is to be given, right? Similarly, as you mentioned, we can see in the box of the severe malnutrition. So this child has also got two classifications. So the treatment of the severe malnutrition, that is vitamin A, the preventing low blood sugar. So we can the baby who is accepting breastfeeding, the baby will be breastfed on the way to the hospital to prevent blood sugar. So, and also these babies, they become hypothermic, so the baby have to be kept warm on the way to the hospital, right? Okay. Would you like to treat anemia in this child? Because you are giving only pre-referral treatment.
So I will give first dose of syrup iron in the dose of 3 to 4 milligram per kg, 20 milligram stat I will give to the child.
Here I want to tell you, Ritu, if you see the box of the anemia, let me, for the viewers, if you see here, for the treatment of anemia, there is no pre-referral treatment which is to be given, because there is no bold letter and this is not an urgency, right? So you only give the pre-referral treatment with the one which is in the bold letters of your classifications. So the iron is not to be given in this child. Okay. And what about the vaccination? You said the DPT and third dose of polio is due. So would you like to give this before sending?
No, sir. Sir, I'll just write it on the pre-referral note that these vaccinations are due but they were not given.
Okay, so that the place where you are referring, that institution can decide later. Okay. Have you mentioned the referral slip actually? Yep. So let us see the sample note of the referral slip. Okay.
On referral slip I wrote that the child was referred urgently to the Safdarjung Hospital, New Delhi.
Okay.
Child's name Asha, 12 months, female, classification, severe pneumonia or very severe disease.
Okay, can we project the referral note? Yeah, we can see the referral note. Yeah.
Now it is.
Yeah, now it's coming. So, okay, so first is urgent referral to a hospital, then we write down the child's name. Okay, then the ID number of the child also should come over there. Next, yeah.
Child's name Asha, 12 months, female. Classification I'll write severe pneumonia or very severe disease, some dehydration, dysentery, malaria, severe malnutrition, anemia. Then about the immunization status, third doses of TPT, OPV and hepatitis B were due but not given.
Okay.
Then the pre-referral treatment, I gave injection chloramphenicol 1 ml IM stat was given. Okay. Syrup chloroquine 7.5 ml was given. Syrup cotrimoxazole 40 mg, which contains 40 mg trimethoprim plus 200 mg sulfamethoxazole per 5 ml. 5 ml stat was given. Tablet paracetamol, I had 500 mg tablet, I gave 1/4 of tablet stat. And vitamin A syrup, which contained 1 lakh international unit in IM per ml, 1 ml stat was given.
Okay. So friend, this is what we have seen, the referral slip, and I would like to have the feedback from my other colleagues also. But please remember here, when you refer a child urgently, the 3 or 4 issues are very important, that you explain the family the need of the referral, and also you calm down the parents' fear, because whenever you tell them their baby is being referred, there must be some fears in their mind, which hospital I'll go, whom to contact there. These are some of the issues which you have to sort it out. Provide the proper pre-referral treatment of the red boxes, and also the treatment of the bold letter treatment of the yellow and the green boxes, and also advise the 4th component, very important, the advice en route. That is what the parents have to do on the way to the hospital, like in this case the ORS is to be given on the way, the baby has to be breastfed on the way, so to prevent the dehydration and also to take care of the low blood sugar. Dr. Prasad, would you like to add in this?
I will just complement or supplement few points. Dr. Ritu has presented the case and Dr. Chelani has moderated it, and Dr. Chelani has explained very well with the help of this chart booklet how to classify the case, what pre-referral treatment is to be given and what advice on way to hospital is to be given, and he has shown a sample of this referral slip also. Well, for examination purpose I want to add that this IMNCI cases are very simple. They are not difficult. You have got two cases in examination, young infant and older child. Just carry your chart booklets with you. Consult the chart booklet consistently and constantly every time. Fill up the form correctly. Case recording form should be filled up correctly with the help of tick mark, fill up the blank and circles. And whenever you are classifying, must consult the chart booklet and must start from the pink or red zone first, then come to the lower rows. Similarly, for the treatment, identifying treatment, you must give priority to the treatment written in bold letters. So that is important. And once you do these things, you will get 100% marks in IMNCI cases, 15 marks in young infant and 15 marks in older child. So that 100% 15 and 15 marks you can ensure only by consulting the chart booklet and filling the form properly. And this is very simple, so don't get any confusion in that. Regarding this, there is two words, assess and check. There are few boxes where you find the check, and those boxes are check for the general danger sign, check for the malnutrition, check for the anemia, check for the immunization status, and iron, folic acid, prophylaxis, etc. Why I am asking this thing, why I am stating this thing, because in her presentation, Ritu by mistake had said, I checked for the ear problem. That should be I assessed for the ear problem. So that point should be borne in mind. Second thing, and another point is that for severe malnutrition, visible severe wasting, it is not only the buttocks. It is always better that you take out all the cloths and examine the baby in vertical position all around, not only buttocks. You can find this, as Ritu has rightly said, more than 2 or 3 folds on the buttocks. You can also see the prominent spinous process. You can also see this scapula. You can also see this wasted shoulders. You can also see the prominent ribs in front. So, and also you can see this thin lower limbs and thin upper limbs. So those points are also important for examining this severe wasting, not only buttocks. So that please keep in mind. Iron, there is one special note for iron I am saying, though Dr. Chelani has already pointed out that this is not in bold letters, so this is not to be given, but any serious acute infection, for first few days we don't give iron. And that is one of the principles of the management of the severe malnutrition also, that even if the child is anemic, for first few days we don't give iron. So these points should be borne in mind.
Yeah. Thank you, Dr. Prasad. I think now we are coming to the end of the second session. We have received facts from Ranchi that 7 students are attending the teleconference there. It is good news. I think you can ask also questions related to IMCI or other areas. We are breaking the session now. We will be meeting again after 15 minutes at 1 p.m. when we will take up some other discussions. Please be with us. Thank you.